outside of the marketplace as well, continuing to be. The thing is, you can't get subsidies if you go through that private market, because you can only get subsidies if you go through the marketplace. So let's say you make $300,000 a year, no chance you're going to get subsidies. So you could go through the marketplace if you want, or you could just call up a private insurance company and go get insurance that way. All those plans are going to be there, all those and providers, and there's going to be a couple more. Aetna and United Healthcare decided not to participate in the Utah marketplace, but they're going to offer plans in the private marketplace out there. So there's going to be some more choices available as well. So yeah, the private insurance market is still going to be out there, but it's not the place to get subsidies if that's what you're interested in. Yeah, I had someone come to our open house who makes $5 million a year talking about this. She's one of the big mommy bloggers in the state. And I was like, yeah, I don't think you need to go through the marketplace. You need to have about 11,000 kids to qualify. So, question over here, right here, sir.
Will the Affordable Care Act ever regulate doctors' income?
No, I don't think so. Let me step back at this. Doctor's income is really based on a couple things. It kind of depends where you work. If you work for a federally qualified health center, it's partially based on what your starting salary is there and the RVUs, the revenue relative value units that you produce, how efficient you are. If you work for a private clinic, it's often based on salary and also your productivity. Usually there's those two mixtures in there. If you work for a hospital, you're a hospitalist, oftentimes it's a set salary. There's actually no product because you do shifts, so you're like an ER doctor. I'm pretty sure they don't have RVUs at ERs, because no one gets shot the night you're working, you still get paid. So I think there's still going to be that kind of diversity of how doctors are paid. And the only thing I could think about it is if there's a better investment in primary care, then there could be people working at the federally funded health clinics. The federal government could say, we're going to pay primary care doctors at FQHCs more, so it's going to increase their salaries in that regard. The other thing it could do is that they could say, we're not going to, the medical evidence says that if you do colonoscopies before age 50, it's not medically necessary. So a certain doctor has built his whole practice on doing colonoscopies before age 50, is all they're going to find that Medicare and Medicaid aren't going to reimburse for that anymore. That could affect their income, so they'd have to shift in that regard. So there's probably a lot of ways that it does, but it's probably not the way you might have been thinking, which is that there's going to be some bureaucrat that says, we're going to pay this doctor $10,000 less, and then put it onto a spreadsheet kind of thing. So, but yeah, great question. It's very complicated. As I found out through talking with my wife, it's, how doctors are paid is as complicated as how lawyers are paid, really. Yeah?
So you said that people really don't get the insurance,
Mm-hmm.
they kind of put money in a pot, but then also hospitals are $60 billion or whatever.
Mm-hmm.
So is any of that money that uninsured, is that going to find its way back to the doctors or the hospitals, or they just go out and that money is going to the government?
Gotcha. So the question was, so the people are paying their penalties because they're not getting insurance, and so where's that money going, and is it going to help compensate the doctors and hospitals that are still providing some of the charity care because their money's being cut as well? Boy, to follow the money would be pretty hard. It really does all go into one big pot. So the money that people pay for penalties is going to support kind of the whole infrastructure of the Affordable Care Act. Paying for setting up the marketplaces to reimbursements to everything. I don't think there's any directed saying that it's going to one kind of thing. In terms of will it go back to the providers and to the hospitals, I think it will in kind of a roundabout way. It's because those doctors and hospitals write off a lot of what they do as charity care, as uncompensated care. And so if more people are encouraged to get insurance by having the penalty out there, and this is a little bit more about incentives and disincentives. Imagine if they didn't have a penalty, and everybody could do Obamacare or not. Then all of a sudden you have a lot more people who say, I don't want this insurance. I'm going to go and I'm going to trust my luck. And if I get into trouble, then maybe I'll pay my bill, but maybe I won't. But now that they have the penalty, there's people who are going to be like, I don't want to pay the penalty. It makes getting insurance more lucrative, so they're going to go get they're going to go get insured, which is going to increase the compensation that's coming to doctors and to hospitals because they no longer have to write off the debt that person would have just walked away from. So that's sort of an answer that I can give you, is that the penalty encourages people to be insured, which increases the compensation that comes to doctors. That's about as close a correlation as I can get to. In terms of where it goes in the big pot, boy, it's messy. If you think my slides are messy, you should see CMS's slides when they try to explain how this works. I don't think you can say that the money is going directly to the doctors. The only way I could say it would be loan forgiveness programs and things like that that are directly targeting providers, are being funded through money that the Affordable Care Act is appropriating. So, in purple, yeah.
With the exemptions on this piece, what kind of relief?
Sure, yeah, I didn't get into that. So the people who are not required to purchase the Affordable Care Act insurance and would not be penalized are, if you earn less than 100% of the federal poverty level in Utah, that's specific to Utah because of Medicaid expansion, you don't file taxes. You're under the $10,000 threshold, or you just don't file taxes. You're undocumented, because you're not eligible if you're undocumented. So, they're not penalized as well. If you are a Native American, it's not whether you use IHS. I learned recently it's whether or not you're a Native American, and you're not required to do that as well, because there's other options out there as well. If you are a member of a religious organization that kind of pays for its own health care, and that would be monks, sisters, people in those kind of organizations, or you're a member of a special group like the Amish. I used to live in Pennsylvania, so the Amish are in a group that they have kind of a community-based healthcare system where everyone pays in and then they pay out. They're not required to do that as well. The organization has to have existed, I think, before 1950. So it's not like you can invent an organization or a religion right now and qualify. So there's some sort of grandfathering that has to go in. Again, that's, there's 100,000 people in Lancaster County where I used to live who are Amish. That's probably the majority of people who are going to be exempt under that category, or right there or in Ohio. So it's not a huge population. Prisoners, people who are incarcerated, are also exempt from it. I'm trying to think if there's any others. Oh yeah, if you live overseas more than 330 days a year, you're exempt from it as well. But if you come home for more than 31 days, then you do have to have some sort of insurance for that. But if you're an expat and you live overseas for more than 330 days, then you're exempt. And there's probably a couple others I forgot, but those are the major ones. Most of the ones are going to be income. If you make less than 100% of poverty, or you're undocumented, then you're not going to be penalized. Other questions? Yeah?
For the federally funded community health clinics, how is the funding going to change for those if more people have insurance? Will there be, everyone's supposed to have insurance
So the question was, how is the funding, and let me tell you if you got this right, how is the funding for the federally qualified health clinics, the CHCs that I mentioned, how is that going to change if more people are getting insured, and they've been serving as kind of like a social safety net for people who are uninsured, as well as people who have insurance? That's a really good question. The FQHCs serve a pretty diverse population. They serve insured, they serve uninsured, they serve documented, undocumented. They kind of have a mix, and each CHC has a different mix based on the geography that they're in. And I wish I had someone from the agency here that could probably explain it better. So if they get more insured patients, either through Medicaid or through insurance, that just means that the people are going to be paying their bills through insurance as opposed to paying it through a sliding scale. Because everybody who walks in, unless you have nothing, is required to at least put $15, $20, $25 down. It's a real sliding scale depending on your income for the care that you receive. So they could be getting more money if people have private insurance or if they have Medicaid. So does that mean that they're going to get less government support? It could be. The government could start actually ratcheting back the amount of support they get. But what we've seen, though, is that Utah's gotten about $4 million of extra investment in the past couple of years to create more clinics. So if that support starts to be taken away, it's certainly not happening right now, and what we're seeing is that there's a lot more investment in putting in these clinics in the high-need areas like South Salt Lake, Vernal, places that really haven't had this kind of access to healthcare before. So I could conceive it, that in other words, sort of like hospitals are losing their charity care payments because they're getting more insured patients. You could see that the FQHCs could lose some of their federal funding because they're getting more insured patients. I just haven't seen anything about that, but you could follow that logic and say, yeah, that could happen. So, yeah.
Is there anything being done to address the two other aspects, quality and cost of healthcare right now in the United States? If not, and also about that, what do you think is the best way to address those two?
Right, those are the what is being done to address quality and cost. The three pillars that I showed early on, Affordable Care Act focusing on enrollment, but quality and cost are sort of the other two things to work on. There are. One of them actually is death panels. You guys all remember death panels? Death panels was all about improving quality and controlling costs, not by taking grandma out to the parking lot and shooting her, as many people thought, but by creating what's known as the IPAB, or the institutional, IPAB, Advisory Board of the last two. I think it's Institutional Performance Advisory Board or something like that. That was a board, a national board that was supposed to say, hey, if you invest a certain amount of money in this kind of care, it's going to create cost savings across the entire spectrum. Here's an example. If you give someone an aspirin when they come into the emergency room with chest pains, the chances that they're going to need an angioplast, getting one of those little tubes that go through their arteries, or the complexity of that angioplast go way, way down. Just by giving them a little aspirin as soon as they arrive to the emergency room. Or if they need an angioplast, getting it done within the first 60 minutes of when they show up and present, as opposed to waiting an hour and a half. The mortality rates, the things like that, go way up the longer you wait. So they figured that out in Florida. They had a lot of old people in Florida, so they figured that out. But they knew that in Florida, but they didn't know that in Oregon. They didn't know that in California. So the IPAB is designed to create incentives that say, hey, emergency room, if you give your chest pain presenters an aspirin, we're going to give you $5. That more than pays for the aspirin, even in a hospital, where the aspirin usually costs $3. And so there's that incentive for the hospital to do that. They get paid, and then the government likes it because all of a sudden, if they don't have to pay for as many angioplasts or as many heart attacks, then they save money down the road. So that's how the Affordable Care Act is slowly moving into cost containment through the death panels, through the IPAB, to sort of do best practices for healthcare, get that out to people, create the incentives, and other things that are disincentives, like in McAllen, Texas, they have some of the highest healthcare costs in the country, and it's because all the doctors were working together, realizing that they could, if they all did it together, then they could really increase their revenue and increase the amount of money they got, and run all these tests and all these things that were completely unnecessary. And as long as they all did it, then they all wouldn't be, no individual person would be in trouble. So Atul Gawande, you guys know him, the New Yorker writer who writes about healthcare issues, he went down there and sort of looked at why McAllen, Texas had the highest healthcare costs and federal reimbursements for Medicare and Medicaid in the entire country. And what the IPAP could do is say, hey, all those unnecessary tests you're running, we're not going to pay for them anymore. And so that's a way that they can cut the costs as well. Bring it down into what the national norms are for providing care.
The iPad is in state right now?
It's not. It's not. It's sort of in dormancy. And remember what happened with death panels? They put it in and then they took it out, and they put it in and then they had to take it out again. So it hasn't yet met. It hasn't yet officially gone into what it's supposed to do. Part of it is that it has to wait for Congress to do some actions, and that hasn't come from Congress yet. So unfortunately, it's a little bit bogged down, or fortunately, depending on how you view it, it's bogged down by some of the politics involved. But that was the aim of the IPAB, was to control costs through incentives and disincentives. Through very simple things like giving someone an aspirin when they show up with chest pains. So simple, but hard to do across the country. Other questions? That was a great question. Anything more? How many folks are going into the medical field, do they think? Healthcare providers. How many people are in education, medical education, things like that? Okay, yeah. How many people are interested in Obamacare insurance? Okay, all right, so we got some folks here too. So, there's a little bit of overlap there. I mean, one thing I say is we do have healthcare insurance through your parents up till age 26. You can stay on that. Or if you have university healthcare insurance, I'm not sure if Weber State provides that, that will also cover you. You won't be penalized if you do that as well. So that gives a lot of students a little bit more time to make the decision. And hopefully the website a little bit of time to get fixed as well. So there's no more questions. I'll be glad to hang out here. Was there a question? Or?
Let's see, I guess I would like to know,
Let me do that real quick. Do you mind if I'll do a quick summary. Medicaid expansion is the major policy issue that faces Utah right now. When the Affordable Care Act was set up, it was designed to be this puzzle that worked together. People would be covered from Medicaid from 0% of poverty up to 100% of poverty, or even up to 138%. There's a bit of an overlap. And then the subsidies would cover folks from 100% of poverty up to 400%, just like that chart that I showed, all the income levels there. It was meant to be a meshed system to cover a lot of people who had either no access to health care or weren't able to afford the access to health care that they had. This was how the law was written. Then along comes the Supreme Court in 2012, and they allowed the Affordable Care Act to survive. Actually, go back one more. But what they did is they broke apart the puzzle. They said that Medicaid expansion is now optional for all states to pursue. So what it does is it leaves people from 0 to 100% of poverty up to the whim of the state about whether or not they're going to do Medicaid or not. So far, about 25 states have decided to expand Medicaid and 25 haven't, or some are like Utah and actually still in the decision process. So the subsidies are intact for people who make from 100 to 400%. That's still there, you know, the helping people out with their monthly premiums. But if you make under 100% of poverty and your state doesn't expand Medicaid, then you're really left with many fewer options, because you can still buy the marketplace insurance, but you can't get the subsidy. It's kind of a weird thing. If you make 102% of the federal poverty level, you're going to get a really, really generous subsidy to buy that insurance. If you make 98% of the federal poverty level, you get nothing. So you can still buy the insurance, but you don't get the subsidy. It's because it was all set up, like the previous slide, to kind of have this system of Medicaid intermeshing with the private insurance subsidies. So that's kind of where we are in Utah right now. We haven't expanded Medicaid. It's still on the table. Actually, there was a big article in some of the newspapers today about sort of the governor's plans on that as well. But that's where we are. If we could jump ahead. What it does is it leaves about 123,000 Utahns in this gap, this group of folks who aren't going to qualify for the subsidies and can't qualify for Medicaid right now. Because in Utah, Medicaid is a categorical program. You have to be low income, but then you also have to be in another category to qualify for it. So you have to be a kid. Kids are covered under Medicaid and CHIP up to age 18, up to 200% of the federal poverty level. So a lot of kids in Utah get covered, which is great, because we have, you know, a lot of kids in Utah, and getting them health insurance is universally deemed to be a good idea. You can be pregnant and get health insurance. You can earn up to 133% of the federal poverty level. 2 months after you give birth, you're probably going to lose it. Your kid will have it, but you won't have it anymore. But it does provide prenatal care to women who are pregnant, including undocumented immigrants. They get emergency Medicaid to cover their delivery. They don't get it to cover their prenatal stuff, but they do get it to cover their delivery, which is important. If you're an adult over age 65, you're a senior, you can get Medicaid if you earn under 100% of the poverty level. You actually get Medicare as well. So you get Medicare and Medicaid if you earn under 100%. Or a person with a disability, you can get Medicaid as well. But the big gaps are adults with children and adults without children. If you have children, you can get Medicaid if you earn under 50% of the federal poverty level, which is about $5,000 a year. If you earn under that, you can get Medicaid. If you're an adult without children, you can't get any coverage whatsoever. There's no Medicaid for single or married adults without children in Utah. So that's really the majority of those 123,000 Utahns that are in the gap are in those top two categories right there. If Utah expanded Medicaid, this is how it would look. People would be eligible for Medicaid, especially adults without children and adults with children, up to about 133% of the federal poverty level. There'd be some boosts for children and for people with disabilities as well. So there'd be a lot more people who would be given this option. The state of Utah actually did a study that pegged it down to 123,000 and actually looked at the costs involved and things like that. So that's sort of the information we're dealing with. But we haven't decided yet. Utah is still in the sort of political process of trying to figure out whether Medicaid is something that, the Medicaid expansion is something that we want to do. And it's very complicated in our state because it's not only a governor decision, but the legislature also has to play a role because of a law that was passed last year, saying that the legislature not only has to appropriate the money, but actually have an up and down vote on it as well. So that's sort of where we are. The governor came out yesterday and said he's not going to put Medicaid expansion into his budget for 2014. He wants to sit down more with the legislature and kind of work this out. So the earliest it could happen in Utah would probably be 2015, which means we'll lose a whole year of a pretty generous federal match, which I'll describe in a, actually, can you skip forward one? Sorry. Because the federal government pays 100% of the expansion cost for 2014, 15, and 16. It's supposed to be a carrot to kind of get states to come in and do this. And actually what it would cause Utah to actually earn money by expanding Medicaid. We get a lot more money than we would be getting right now. After 2020, that federal match drops down to 90%. The federal government pays 90% of the cost, the state pays 10%, which is still better than our current matches where the federal government pays 70% and the state pays 30%. Medicaid policy is a crazy subject. I'm really glad that Riley, my colleague, is in the back of the room, so she's our Medicaid specialist. You can shout out if I get this wrong, okay? Is that all right? Am I doing good? Okay. What it would be, though, is if Utah actually expands Medicaid, it would end up costing the state about $25 million a year in extra costs. So it is an expense, and that's one of the things that Utah is debating. Is it worth it to spend $25 million or $35 million a year to add insurance to an extra 123,000 people? And that's really one of the big issues. The other is that there's always been some suspicion of federal programs and government programs in this state, and Medicaid certainly falls into that kind of a category. And so there's some other kind of resistance to expanding Medicaid just beyond the fiscal cost of it. Some of the states that have expanded Medicaid include Ohio, Arizona, and New Jersey. If you notice, those are all led by Republican governors. So it has really stopped becoming a strictly red state, blue state issue. It's really a state-by-state issue based on looking at the numbers and seeing what can get done legislatively and in the executive leadership of each state. Jump to the last slide. Yeah. So this is how the country actually looks. Utah is kind of leaning towards no. I think we actually are maybe a little bit more purple now based on some of the new news we got. But the blue states are the ones that are expanding Medicaid. The dark red states are the ones that aren't. The sort of middle ground states are the ones that are kind of in the middle trying to decide. And if Utah were to expand Medicaid, if it were to happen, it would actually be a lot like what's probably going to happen in Arkansas or Iowa, which is what is known as a hybrid model, which is instead of doing a full expansion like they did in California or other states like that, we would give Medicaid to certain groups of folks, maybe up to 100% of the federal poverty level, and then we would actually give subsidies for the rest of them to get private insurance in the private market. So it'd sort of be extending the Obamacare subsidies down to a smaller or larger group of people. And it could even divide it up based on substance abuse or age and things like that. They could slice the pie a couple different ways. So that's what Utah, if we were to do it, it would probably be like an Arkansas model is what they call it. The challenge is that those models usually end up costing more. Medicaid, just traditionally expanding Medicaid is the most efficient way to do it. But in some states where that's politically not possible, these other alternatives have gotten approval from the federal government, but they end up costing the state more money. So we'd be paying to do something a little bit more unusual if we decided to do it. Currently, as I mentioned, about 25 states, this is a little bit outdated, sorry, from September, 25 states are leaning for it. The latest one was Ohio, where Governor Kasich there kind of went around his legislature to get it done about 2 weeks ago. If you could go back one slide. I'm sorry, I'm kind of jumping. One more, actually. So these are the options that are on the table right now. Full expansion, hybrid expansion, which is that Arkansas model, charity care, which is something that certain groups here in Utah are very interested in doing, block grants, or doing nothing. The one that I think could have the biggest sort of chance of success would be the hybrid expansion model. Again, the kind of giving some people Medicaid and giving other people subsidies to get private insurance. What it would do is it would bring that extra 100,000 people into the insured system. So because right now when we go out and we do enrollment events, we have people come up to us and we plug their numbers into the computer, and if they make 110% of poverty, there's a big smile on their face because they know they can get the Obamacare insurance and get a generous subsidy to afford it. But if they make 95% of poverty, we have to kind of explain to them, I'm sorry, there's no options for you right now. And they get pretty upset because they thought that this was going to be something that could help them. And it actually, right now in Utah, isn't. So, what do? Go get another job, try to boost their income, move to another state. Those are the options that are available for them. But until Medicaid is expanded, there's not going to be the insurance option, at least presumably an affordable insurance option that they can do. There's a lot of controversy around this, a lot of politics around it. What we try to do is we try to focus on what are the fiscal arguments, both in favor of it and against it, and try to deliver that advice through the presentation. But sometimes it's hard to ignore those people who come up to you and fall below the threshold and realize that their family isn't going to get insurance because of this.